labor. What is induction and what is augmentation? Induction is the start of labor process. Augmentation is when the labor process already started. However, we just accelerate the labor process. These are the indication of induction. Maternal reason due to post-date, GDM, PIH, severe preeclampsia. Fetal reason, the IUGR or FGR, PRM more than 24 hours, PPRM above 34 weeks more than 24 hours, termination of pregnancy, and IUD. From here, we can separate this chart into 34 weeks and above, 38 weeks, 36 weeks, 38 weeks, 40 weeks, and 40 plus 7 days. For ANC uneventful, we may allow post-date. However, for GDM and PIH, you may not, because there's a probability of placenta insufficiency due to the calcification of the placenta due to the GDM and PIH. For GDM on diet control or PIH not on treatment, we may allow up to 40 weeks. However, GDM on insulin or PIH on treatment, we should IOL at 38 weeks. Okay. For PPRM without chorioamnionitis, we may deliver them after 36 weeks, 36 to 38 weeks. For PPRM with chorioamnionitis, between 34 to 36 weeks. Okay, always PPRM aim towards term. Other than that, IGR, severe preeclampsia, we aim to IOL between 36 to 38 weeks. These are the contraindication for induction. CPD, placenta previa, abnormal lie, especially the transverse lie, is contraindicated. Bridge only relatively contraindicated. Previous scar, there are 2 previous scar, more than 2. Other than that, if the patient had comorbidities such as heart disease, NYHA 3 to 4, tak boleh IOL. Severe pulmonary hypertension, tak boleh IOL. HIV positive, CD4 more than 40, tak boleh IOL, kena Caesar. These are the risks of IOL. It can cause hyperstimulation of the uterus, which cause fetal distress and death, and it also can cause uterine rupture. IOL can also fail, leading to C-sec. So preparation for IOL, we must establish the indication clearly. We discuss with the MO or specialist. Take informed consent, and then we confirm the gestational age, assess the fetal size and presentation, and also pelvic assessment to avoid the CPD risk. Also avoid transverse lie. We do cervical assessment by Bishop scoring, and make sure there's a MO and specialist around if anything happen, and then do CTG. Okay, this is the Bishop scoring for cervical assessment. For Bishop score, more than 5, it should augment, less than 5, induction. This is an example of a case where we induce vulva vagina, no abnormality, os 1 cm, cervix 2 cm posterior, soft, station -2. So the Bishop is 3. So what we do to this patient, we induce, push the patient to the ward. Make sure to do CTG, and 1 hour later, then only we do IOL. This is an example of a patient that we augment. Vulva vagina, no abnormality, os 4 cm, cervix 1 cm axial, soft, station -2. So the Bishop score is 6. So this patient we should augment and push to labor room. Method of induction, there are 3 types: traditional, mechanical, or medical. Traditional, the most common is by encouraging SI more than 36 weeks, because the semen have prostaglandin. Then we encourage patient to walk, and or the patient may also apply virgin coconut oil. For mechanical IOL, there are 4 types of mechanical method: sweep and stretch, the intrauterine catheter, dilapan laminaria, which is a hydrophobic dilator, and also ARM, the most commonly done ARM. Okay, stretch and sweep to release connective tissue and release prostaglandin. Also, the intrauterine Foley catheter also can release connective tissue and release prostaglandin. The Foley catheter will inflate at the cervix, 40 to 50 cc. Dilapan, which is or also called laminaria, we insert about 2 to 3 sticks at the cervix. This is a hydrophobic dilator which absorb water at the area and the cervix will dilate. ARM is the aim is to augment the labor, or IOL. Medical method is by using by using prostaglandin E2. It is a vaginal pessary, usually given 1 times per day, maximum 3 times, inserted at the posterior fornix near the artery areas for cervical priming. Usually it's 3 mg pessary. For patient with previous scar or and para-3, we insert only half of it, which is 1.5 mg. Those with allergy or contraindicated for SVD or IOL should not be given prostin. The risk of prostin is hyperstimulation, which is the contraction is more than 5 in 10, which can cause fetal distress. For patient para 3 and below, we usually IOL with prostin. However, para 3 and above, we use mechanical method. For PRM more than 24 hours, usually we use prostin.